was recently joined our faculty here at Yale. It's a real pleasure to have us as part of our team, and we're very honored that she'd be able to speak to us today. Dr. Banini has an illustrious career. Even prior to joining our section, she had her MD and PhD from Thomas Jefferson University, which I know very well, and so I'm very proud of that affinity that we have. And she went on then to become resident and chief residence at Montefiore, had an extensive research training as well, both at Mayo and at VCU. And we were very lucky to have her come join our section, and in which she is the translational research director for our metabolic and weight management program here at Yale. I think Dr. Banini is a wonderful clinician and also has a very in-depth research expertise that she's now applying to the study of fatty liver disease. So we're, again, thrilled to have her, adding her voice and her experience to our center. And we are very excited to hear about some of these innovations now, which I fairly sure I cannot always keep track of at this point in terms of the latest in fatty liver and some of the approvals for medications. So once again, thank you so much, Dr. Banini, for your presence today with us.
Thank you for inviting me, and thank you for that introduction, Dr. Assis. I'll go ahead and share my screen now. All right, so I'm trying to okay, so can you guys see my screen?
Yes.
Okay, perfect. So I do want to thank the organizers again of the Connecticut advisory of the American Liver Foundation for the opportunity to speak to you today about new frontiers for fatty liver disease and an update on clinical trials and drug approval status. So in this talk today, I hope to accomplish the following objectives. Described to you NAFLD as part of a multi-system disorder. Describe patients within the NAFLD spectrum of disease that will benefit from pharmacological therapy. Discuss the endpoints put forth for assessing efficacy of drugs undergoing clinical trials for NASH. Discuss the current landscape for NASH drug development with focus on drugs currently in the phase 3 trials. And then to give a very brief overview of how our treatment paradigm for NASH would be in the next decade. So NAFLD is part of a multi-system disorder which rests on diet-induced obesity. So with obesity, there is a continuous inflammation leading to metabolic stress and systemic inflammation. Ongoing and repetitive inflammation eventually results in fibrosis. This fibrosis, aside from happening in the liver, can also be happening in other organs. The inflammation and fibrosis can also be occurring in other organs. In the arteries can lead to vasoconstriction. And as I mentioned, the fibrosis can eventually result in hypertension, cardiovascular disease, CAD, and peripheral vascular disease. In the heart, we know that the heart failure with preserved ejection fraction is a common feature of patients with NAFLD. I mentioned occurring predominantly in the liver, and that inflammation can also be occurring in the pancreas, predisposing to type 2 diabetes mellitus, as well as in the kidneys, resulting in chronic liver disease. So you see the spectrum of disorders that are commonly co-occurring in patients with NAFLD. These lead to various outcomes in several organs, that can increase mortality in these patients, including cardiac outcomes, vascular outcomes, kidney outcomes, cancer, as well as in liver outcomes as well. So in the US population, which mirrors to a large extent what is going on in other Western countries as well, we know that there is an increased incidence of NAFLD. It's been estimated that approximately 31% of the population has NAFLD. This is especially prominent in patients with obesity and metabolic syndrome, with estimates going as far as about 90% of patients with obesity and metabolic syndrome having NAFLD. NAFLD is the most common cause of chronic liver disease worldwide and has become an increasing cause of liver transplant worldwide and currently surpasses hepatitis C as a cause for liver transplant. So we know that NAFLD has a wide disease spectrum, starting with hepatic steatosis, which we otherwise referred to previously as simple steatosis. Eventually, we can get steatohepatitis, which is characterized by ballooning and inflammation in addition to the steatosis. Over time, this can result in liver fibrosis, and severe fibrosis, by definition F4, is cirrhosis. So you see the spectrum that can occur with time. We know that fibrosis is the strongest predictor of liver-related outcomes. On the left graph, you see the Kaplan-Meier curve for development of severe liver disease and complications of severe liver disease stratified by fibrosis stage compared to matched controls. So with progressive fibrosis, you see an increased occurrence of these severe liver disease and complications that are associated with it. On the graph on the right, you see overall mortality, again, stratified by fibrosis stage. So at fibrosis stage 3 or bridging fibrosis, estimates put the risk of mortality at 6 times that of matched controls. And by F4 fibrosis, it's about 11-fold increase in mortality compared to matched control. So this just emphasizes the predictive capability of fibrosis in predicting decompensation and mortality in these patients. So in terms of dealing with NAFLD, we not only have to address the liver, but also to keep in mind the threats to the patient in terms of worsening of other organs, like I mentioned. And so to address this in a holistic manner, we do have to address what is going on in the other organs, including the arteries, where we have to work on blood pressure control and atherogenic risk, as well as vascular inflammation. In the heart, we need to address the diastolic dysfunction and commonly QTc abnormalities that are occurring in these patients. In the liver, again, preventing progression to advanced liver disease and decompensation, including the development of liver cancer. In the pancreas, preservation of pancreatic function, and in the kidneys, how we can stabilize the kidney disease. So in order to address this, we have to really treat the root cause, address the root cause, which, as I mentioned, to a large extent is obesity that is induced by diet, which sets up this cascade of metabolic stress, inflammation, and fibrosis. So then again, addressing the root cause is about losing weight. And of course, it's easier said than done. We all know that. But weight loss has been shown to have a positive ramification for all these end organ damage that I mentioned. So I would be remiss if I didn't mention weight loss in this talk as the first and foremost treatment for NASH. Again, treatment of obesity is the foundation of cure for this disease. It's been shown that a BMI reduction of 5% is associated with 25% relative reduction in liver fat as measured by MRI proton density fat fraction, MRI-PDFF. Similarly, 4 to 10% reduction in weight results in improvement in liver fat and serum aminotransferase levels. So a study by Villa-Gomez et al. In 2015 looked at about 261 patients with NAFLD through paired liver biopsy, and showed that with weight loss, there is a progressive improvement in liver histology. So in the very bottom bar, you see that greater than 3% weight loss led to resolution or improvement in steatosis in about 35 to 100%. Again, looking at both Villa-Gomez and the range of other studies as shown at the bottom. With more weight loss of 5% or more, you can get a significant improvement in ballooning and inflammation. Of course, with the higher probability, depending on how much weight you lose. With 7% or more weight loss, there is potential to resolve NASH in about 64 to 90% of patients. And with greater than 10% weight loss, you get improvement in fibrosis in almost half of the patients. But in reality, how well can patients lose weight? We know that for patients who take it upon themselves to lose weight in the setting of NAFLD, only about 30%, about a third of them can do so in a year. If the benchmark is 5% weight loss. If you increase the benchmark to 7% weight loss, just about half of that, so about 18% can do that in a year. And then when you talk about losing more than 10% of your body weight, less than 10% of those patients actually can do so in a year. And like I said, it's easy to lose weight, but in reality, a very small minority of patients can do that successfully and also be able to maintain that weight loss. So this sort of provides a context for why we need pharmacotherapy for NASH. Again, I've shown you the spectrum of liver disease occurring in NASH. And so the focus of pharmacotherapy is to address patients who have developed fibrosis so typically F2 to F3 fibrosis, as well as those who have progressed to F4. So for improvement in histology, which is required by the FDA in doing a phase 3 clinical trial for NASH, we need to look at the NAFLD activity score, which is based on steatosis, ballooning, and inflammation. And as you can see in that table, based on the level of these histological features, you can provide a score from ranging, a total score ranging from 0 to 8. You also look at the fibrosis score with no fibrosis giving a score of F0 ranging to cirrhosis, which is a score of F4. And so for clinical trials in phase 3, really the recommendation is that patients should have a NAFLD activity score of greater or equal to 4 and a fibrosis score of greater or equal to F2. And so by definition, this is fibrotic NASH. So again, the focus of these clinical trials in patients with the NAFLD disease spectrum is to target patients with fibrotic NASH, which is the NAFLD activity score of greater or equal to 4, plus a fibrotic score of greater or equal to 2. So this then tells you that a liver biopsy is required, both in the beginning of the study to demonstrate the baseline histological score, as well as at the end of the treatment period to show that these histological measures have improved based on the trial that you've administered. So the FDA efficacy endpoints for phase 3 trials rest on demonstration of histologic improvement. So this is based on NASH resolution or fibrosis improvement. For NASH resolution, you would need to demonstrate the resolution of steatohepatitis on histologic reading. So then by the end of the trial, the if inflammation should be 0 in these patients with no worsening of liver fibrosis. So again, with NASH resolution, you're looking at resolution of steatohepatitis with no worsening of fibrosis. And in the fibrosis improvement, you're looking at improvement in fibrosis greater or equal to 1 stage with no worsening of steatohepatitis. So you should be able to demonstrate these endpoints in your clinical trial, either separately or in combination. So you all can also have composite endpoint, which is looking at both of these measures. So basically, the reason for looking at histologic improvement is really that it is a surrogate for clinical outcomes. So in this, you're looking at, like I said, the NAFLD activity score, which gives us a sense of the disease activity. So how active is the disease, is the inflammation, how active is the ballooning in these patients. And you're looking at fibrosis, which is what stage of the disease is the patient. Are they at F0, F1, F2, F3, or F4? And so these surrogate measures then translate to clinical outcomes, which essentially the risk of having decompensation or death in these patients. So in the short term, again, we're looking at improvement in histology, which is based on activity, NAFLD activity score, and fibrosis, which is a surrogate in the long term for clinical outcomes. So I mentioned the histological scoring. There are also a number of non-invasive tests that are being developed and which appear to be promising. So just to mention some of them, the MRI liver fat fraction, as I mentioned, has been shown that over 5% absolute improvement in the MRI PDFF or greater than 30% relative reduction is associated with improvement in the NAFLD activity score. we can also look at the MRE, which has been shown that 15% or more reduction in that measure from baseline has a pretty good correlation with improvement in the NAFLD activity score. We are very well, all know the FibroScan, which gives us a liver stiffness measure. With that, 20% or more reduction from baseline is associated with improvement in NAFLD activity score. And then in regards to the ion corrected scoring, about 88 greater or equal to 88 improvement in that score has been correlated with improvement in NAFLD activity score. There is also some evidence for looking at biochemical measures, in specific the aminotransferases AST and ALT, with greater or equal to 17 units per liter decrease in those measures, predicting histological response on liver biopsy. So these are being developed further, but they definitely have not taken the place of histological scoring as a measure for the effectiveness of drugs undergoing clinical trials. So just again, an overview. So basically, the perspective on who should be treated and what effective therapies can accomplish. Basically, we are looking to try these medications in patients with NAS score greater than 4 and fibrosis stage 2 to 3, or those with fibrosis stage 4, which I mentioned earlier is continuing to be a significant problem, especially in Western society. So the expectation of any effective therapy for NASH is that it will slow down or reverse progression to cirrhosis in these patients. So basically, we're taking these patients with that are defined for you, and we are preventing them from moving on to the next stage, which is NASH, which is cirrhosis, which is associated with complications and mortality. So there are a number of clinical trials that are currently ongoing to test pharmacological therapies in NASH. This is an adaptation of a figure I made a few years ago, and I've added some newer tests that are going on in the field. This is by no means comprehensive at all, because there are hundreds of drugs in the pipeline of testing from phase 1 through phase 3 trials. But what you can notice from this figure is that these drugs are targeting a number of different mechanisms, with some working on the fatty liver in terms of trying to reduce steatosis, insulin resistance, and metabolic stress that defines the beginning stages of this process. Others are addressing the steatohepatitis through modulation of oxidative stress, or targeting apoptosis or cell inflammation and injury, while others are trying to target the more advanced stages of fibrosis and cirrhosis. This is about a $40 billion race to find a therapy that is effective in these patients in reducing progression of disease. So I'm going to focus the rest of the time on the medications that are currently in phase 3 clinical trials. And these include a Semaglutide, which is a GLP-1 agonist, Lanifibranor, which is a PAR agonist, resmetirom, which is a thyroid hormone, specifically the beta receptor agonist, and obeticholic acid, which is an FXR agonist. So I chose to talk about semaglutide first because I think that compared to the others, it really has the potential to emerge in the near future, since it has a lot of ideal characteristics that are effective in therapy, potential therapy for NASH. So we know, first of all, that semaglutide causes significant weight loss. It was just approved as a weight loss medication a couple of months ago, based on especially this study that shows that with progressive increase in the dose of semaglutide up to 0.4 milligrams daily, you get a significant reduction in weight in these patients compared to placebo. So semaglutide, which is a GLP-1 agonist, has potential metabolic effects on the liver as well as in several organs. If you recall back to my earlier slides, the metabolic stress and inflammation and eventual fibrosis that is happening in the liver is happening in other organs as well. So ideally, medication that is effective in NASH should also have potential effects in improving the other organs. So we know that GLP-1 has been shown to decrease platelet coagulation, has some cardioprotection effects. It's known to increase natriuresis and diuresis, which has positive effects on the kidney. It's known to decrease blood pressure, as well as, again, affect a number of other organs that are undergoing metabolic stress, which you will find in these patients with NAFLD. In regards to NASH specifically, what you see on the right side, it appears to decrease inflammation, to decrease fatty acid storage, as well as triglyceride and free fatty acid reduction. It improves glucose metabolism and glycogen storage, and also has an effect on improved hepatocyte survival. So again, looking at other organs, GLP-1 agonists are known to reduce all-cause mortality, hospitalization for heart failure, and improve kidney status in patients with type 2 diabetes. This is probably small and you may not be able to see it, but here we see all-cause mortality in the first section, hospital admission for heart failure in the second section, composite kidney outcome, including microalbuminuria in the third section, and kidney function in the fourth section. As you can see with this meta-analysis, GLP-1 agonists have a favorable advantage on all these measures in this figure. So basically, I mentioned the role of weight loss, and I have included here as well the GLP-1 in improving the function of other organs that I mentioned, in addition to other medications that have been shown to improve function of these organs. So in specific, going a little bit to the effects of semaglutide on NASH, on the graph on the left side, you see that with progressive increased doses of semaglutide up to 0.4 milligram a day, which is actually equivalent to the current dose that we use that has been approved for weight loss, which is about 2.4 milligrams injection a week. There is about a 59% resolution of NASH with no worsening of fibrosis, compared to 17.2% for patients with placebo, and this is statistically significant. For fibrosis, there is a reduction, although non-significant, in patients who administered semaglutide versus placebo. So semaglutide has been shown to improve histological scores for NASH. The graph on the left is change in lobular inflammation. And so look at the hashed area of these bars. So really the bottom part of these bars. And you can see that these hashed areas for all doses of semaglutide are higher than for placebo, which is the gray bar. In terms of hepatocyte ballooning, also there is an increase in the proportion of patients with hepatocyte ballooning for all doses of semaglutide compared to patients on placebo. The fibrosis effects of semaglutide also appear to be somewhat promising. And as I mentioned in the previous graph, there is an improvement in fibrosis over placebo. However, this is non-significant based on the current data that we have. So moving on to the next medication in the phase 3 trials. Lanifibranor is a it's a pan-PAR agonist. So basically, we have the alpha, beta, epsilon, and gamma receptors, which all control different mechanisms or different pathways in the body. With the PPAR alpha agonists, those are involved in lipid catabolism, control of inflammatory processes, and specifically in the liver, increased fatty acid oxidation, increased fatty acid uptake, and in the vessels, increased triglyceride and decreased fatty acids, as well as decreased cytokines. The beta and epsilon receptors are responsible for insulin sensitivity and glucose homeostasis. So they have adipocentric action as well as action in the skeletal muscle to improve insulin sensitivity. And then the gamma receptor is involved in glucose homeostasis and lipid storage, again, as well as in skeletal muscle and adipocyte function. So lanifibranor actually acts to agonize all the different receptors. So in terms of the clinical trial of lanifibranor in NASH, this was a phase 2 clinical trial that actually was just published in the New England Journal of Medicine within the past 10 days. So basically what they did was to randomize patients with highly active NASH 1:1:1 to receive either 2 doses of lanifibranor, 1,200 milligrams or 800 milligrams a day, or placebo for a period of 24 weeks. Patients had baseline biopsies prior to starting on the medication, as well as biopsies at the end of the trial period at 24 weeks. The primary endpoint was a decrease of greater or equal to 2 points in the SAV score. So this is looking at steatosis, activity fibrosis, as well as incorporating scores for ballooning and fibrosis. So this was a decrease of, again, greater or equal to 2 points without worsening of fibrosis. And the secondary endpoints included resolution of NASH and regression of fibrosis. So this is the figure that shows their outcomes, both primary and secondary. So in patients who received placebo, 33% of patients met the primary endpoint. This is compared to 48% of patients on the low dose lanifibranor and 55% of patients on the higher dose lanifibranor. So there was a statistically significant decrease in patients who were on high dose compared to placebo with a p-value of 0.07, whereas those on the low dose approached statistical significance but did not make it with a p-value of 0.07. Sorry, 0.007 for those on the high dose p-value and 0.07 for those on the low dose Lanifibranor. And this also shows their secondary endpoints, resolution of NASH without worsening of fibrosis, which was met by 39 and 49% of patients on the low and high dose compared to 22% of patients on placebo. Improvement in fibrosis stage of greater than 1 without worsening of NASH, which was met by 34 and 48% of those on low and high dose compared to 29% of those on placebo. And then they also had a composite secondary endpoint, which combines resolution of NASH and improvement in fibrosis greater than stage 1, which was met by 25 and 35% of patients on low and high dose compared to 9% of patients on placebo. So overall, this appears very promising as a potential therapy for NASH, and this is currently in phase 3 trials. The next medication that I'll highlight briefly is resmetirom, which basically is a selective thyroid hormone receptor beta agonist. So the resmetirom really is an acronym for resolution of metabolic syndrome by this thyroid medication, which increases hepatic fat metabolism and reduces lipotoxicity. This study was done in patients with biopsy-confirmed NASH, fibrosis stage 1 to 3, and as well as hepatic fat fraction of at least 10% on MRI-PDFF. Patients were randomized 2-to-1 to receive resmetirom 80 milligrams or matching placebo daily. And so about just over 80% were randomized to the medication, with 84 patients to the drug and 41 patients to placebo. So on this figure, you see on the left side, the relative reduction in hepatic fat, as well as absolute reduction in hepatic fat. And this was favorable for patients with resmetirom compared to placebo. In terms of looking at their histologic scores, about 39 patients on resmetirom had improvement in their NAFLD activity score compared to 6% of patients who got placebo. I want to touch briefly on obeticholic acid, which is an FXR agonist. We know that the FXR and RXR pathways are involved in a number of pleiotropic processes in the body, including cholesterol metabolism, glucose metabolism, triglyceride metabolism, as well as in the vasculature. So obeticholic acid was looked at in the Regenerate trial, which the target was about 2,400 patients with biopsy-confirmed NASH with NAS score of greater or equal to 4 and F2 or F3 fibrosis. The interim analysis was done at 18 months, and additional histologic outcomes included progression to cirrhosis, looking at decompensation, progression to decompensation, including ascites, SBP, variceal bleed, hepatic encephalopathy, HCC, liver transplant, or eligibility for liver transplant. So the interim analysis at 18 months showed that in terms of patients who had fibrosis improvement with no worsening of NASH, the 18 milligram dose, for the 18 milligram dose, 18% of these patients met this outcome. This an error here, as opposed to 12% of patients in the placebo, who received placebo. For patients who received 25 milligram dose, there was an improvement in this primary outcome of 23% versus 12% of patients who received placebo, and this was statistically significant. In terms of patients who had NASH resolution with no worsening of fibrosis, there was no statistical difference in the three arms. It was concerning, however, that these patients had pruritus. Over 50% of patients involved in the study had
found one
pruritus.
option. Paul and Eddie's Pizza on Whitney Avenue in Hamden. Do you want that one?
And also, there were patients who had increased LDL and decreased HDL, as well as concern for cholecystitis and hepatotoxicity in these patients. So based on these side effects, the FDA failed to grant approval. But this study is still being looked at, and it's possible that in the near future, it may emerge potentially as a treatment for NASH. So just looking at the frontline therapies that I mentioned in terms of the PPAR agonist, FXR, thyroid, the thyroid beta pathway modulation, and GLP-1 agonist. Here you see a summary of their different effects, from weight gain to change of the lipid profile to endpoints for cardiac events. So MACE stands for basically adverse cardiac events in these patients, stabilizing of the renal function, glycemic control, and reducing progression to NASH. And as you can see from these tables, we still have question marks in a number of areas. However, again, I want to highlight a GLP-1 agonist, which compared to the others, really seems to have a favorable profile on a number of outcomes. So basically, in terms of projecting for the next decade, for how we may treat NASH in the coming years, the prediction is that we would first start with a focus on weight loss, which is what we do now. So this would be the first line treatment for these patients. And then drugs will come in as a second line. There would be an attempt to modify the risk factors. For instance, the using of statins in these patients as indicated for those with dyslipidemia, as well as use of fibrates if indicated. And then GLP-1 agonists, most likely, or SGLT2 inhibitors, would be one of the earlier medications that would be used if weight loss failed to achieve a significant improvement of NASH in these patients. And then from there, for patients who still have residual active disease, despite what I've mentioned previously, then there would be targeted therapies that will aim to address active NASH and prevent it from progressing or reverse NASH in these patients. There also would be a role for combination therapies. As I showed you in the slide with all the different studies that are currently ongoing, these studies are targeting a number of pathways. And so that poses a role for combination therapies that will be addressing more than one pathway or a number of different pathways that will then improve the efficacy of these medications. And overall, the hope is that it will improve outcomes in terms of mortality, healthcare costs, and function of these individuals with this multisystemic disease. So this is my last slide in terms of a few take-home messages. I've told you that the target population for NASH therapy is those with NASH. Again, NAFLD activity score greater than or equal to 4, and those with fibrosis of F2 or F3, or those with NASH cirrhosis, by definition, F4 disease stage. The efficacy endpoints for phase 3 trials are based on histologic improvement of the liver, and this is a short-term surrogate endpoint that translates into reduced clinical outcomes. I've mentioned that there are several promising non-invasive treatment options that are emerging. For instance, the MRI-PDFF, the MRE and liver stiffness measure, as well as biochemical measures. There are several drugs that are currently in the pipeline of testing for NASH, with some in the phase 3 trials that I've highlighted. And we anticipate that the first drug approval for NASH will likely occur within the next 1 or 2 years. I've also touched briefly on the management paradigm for NASH in the next decade, which will likely involve a stepwise approach, with the first focus on weight loss and risk factor modification, and subsequently using GLP-1 agonists and SGLT2 inhibitors, and then from then on to use NASH-directed therapies if still in need for treatment. So I want to thank you for your attention, and I also want to thank Dr. Senyal, who lent me some of the slides that were used in this presentation, and I'll be happy to take any questions.
Thank you so much, Dr. Banini, for such a comprehensive discussion about this very cutting edge topic. I agree also with the recent articles only 10 days ago. There's a lot happening in real time. So it's really wonderful. Thank you so much.
Thank you.
I think there are a few comments here. I'm happy to read them out. And then of course I have a few questions also. There is a question in the chat box about the role of bariatric surgery in management of NASH. And then a second question about perhaps, very importantly, about NASH recurrence and prevention of that after transplant.
Great. Yes, so there definitely is a role for bariatric surgery, and I didn't touch on that, but yes, so for patients who lose significant weight after bariatric surgery, it has been shown that there is an improvement in the histologic scores for NASH. So definitely that has a role to play for a weight loss, and that leading to improvement in NASH. And then the second question about recurrence of NASH after liver transplant, I think that just goes to show us the intrinsic multi-systemic nature of the disease. So that even if you were to just take out the liver, which is cirrhosed and at its end stage, and put a new liver in, the inflammation that is ongoing in the body that eventually led to fibrosis and cirrhosis has to be curbed. So then that also calls into question whether these drugs that are addressing systemic inflammation on a comprehensive scale may have a role for preventing recurrence of NASH and cirrhosis in these patients who have undergone liver transplant. So I foresee that in the near future, once we have medications that are curbing the progression of this disease, that we would try them also in patients who have undergone transplant in an attempt to see if, especially those who start to show signs that they're developing NASH again, there may be a role for using these medications to prevent progression in these patients.
I completely agree, especially given years ago the experience with recurrent hepatitis C post-transplant. You think about all the organ allocation, so preventing that is going to be critical once there's drugs approved. So
absolutely.
Thank you. Other questions from the audience? Dr. Boyer.
Very nice presentation, Bubu. I enjoyed that very much.
Thank you.
Now, I don't keep up with this area very often, so it was a great review. What about other fibrates? Lanifibranor, I know, has had some attention in this field. Are there any other fibrates that are promising, or is Lanifibranor the only one?
So Lanifibranor is one. There were a couple that I mentioned in the slides as well. And I'm not, so, again, I focus on the phase 3 trials, but there definitely are some. Let me go back. Let me try and go back to that overview slide that I presented before.
Hard to see.
Yes. Yes, I'm actually looking at it for myself as well.
Down in the left-hand corner, I guess, right? No, those
Right.
are GLP. Those are GLP.
Actually, I think I may have deleted, but I think Lanifibranor is the one that stands out in terms of the ones that are currently undergoing for the testing.
Is that now entering phase 3, or did it fail phase 2?
Lanifibranor is currently not in phase 3 trials. Yeah.
Thank you.
Well, I have a question. Hey, Mario, go ahead, please.
No, Bubu, that was wonderful. I probably because my Zoom went off for a second. I like to ask you a clarification. So, what is the first step therapy that you implement? Is weight loss, or you immediately add GLP-1 treatment and so on?
Thank you, Mario. I would first implement weight loss.
Okay.
Because I as I mentioned earlier, and again with your Zoom, you probably couldn't hear. So weight loss has beneficial effects on a number of organs, not just the liver. We know that there's improvement in cardiac function, improvement in pancreatic function, improvement in kidney function. So there still is a role for weight loss in these patients, and that would always, I think, should always be first line. And then if they are not able to lose weight significantly, and I mentioned that only about 10%, when it comes down to it, actually less than 10% of patients can lose over 10% of their weight and keep it off for 1 year or more.
Yes.
And so it's hard to lose weight. Definitely the focus should still be on weight loss, but it's hard to do that. And so there will be a role for these medications.
And what is your cutoff to decide when weight loss is
failing?
Not going to happen? I mean, because it's a struggle sometimes. But do you have like a rule of thumb when you decide, okay, I have tried, and then I go with pharmacologic approach?
Yeah, that's a great question. I don't know whether we have a particular number that we can go off. So usually by the time the patient comes to see you, they've tried to lose weight for many, many, many years.
Okay.
And and sometimes they lose and they gain, and they lose and they gain. And so it's been several years of trying unsuccessfully to maintain weight loss or to even lose it. And so when I see patients with NASH, and I hear their stories of how they've struggled for so many years to lose weight. Granted, there are some patients who don't know that weight is a contributor to their disease. And I think there is a role to explain that to the patient, that, there is a correlation between your weight and, progression of, and first formation of the disease and then progression. And so if they want to give a try to work at losing weight, I think that's reasonable. If the story is that we've tried so many years and we're not losing weight, then I think at that point you really should talk about starting some therapy. So now we know that Semaglutide is approved for weight loss in these patients. And so that is a conversation I have on day one when I know the patient has tried for several years to lose weight and they're not losing it. I ask them about potentially going on something like Semaglutide or metformin to help with their weight loss endeavors.
Gotcha. Thank you very much.
Sure.
Well, I have a quick question, which is, I was struck by the placebo response in about up to 33% of patients in the Lanifibranor study. And so I don't know, I'm sure you have a much better sense for this than I do, but I imagine everybody who was in that trial got super motivated to get their act together from a lifestyle perspective. And so that alone accounted for, I imagine, some of the placebo effect, but then subtracting the placebo effect from the drug effect leaves you with 18 to 20% attributable to the drug. So do you have any sense in the real world as to how well these potential drugs might work without weight loss? Because it may, how would it even assess that? I'm not quite sure.
That's a great point, David. And so I think, again, it underscores the role of weight loss and diet, lifestyle, changes in these patients. Because you're right, once you're in the study and you know more about NASH and the underlying factors and how you can modify your disease, then you get more serious with losing weight. And so I think to a large extent that accounts for the large placebo effect that we see. In real life, it's somewhat hard to predict, but I don't know that real life will be different from what we're seeing in these trials, with a relatively modest improvement in disease compared to those who lose weight. And so again, I think that also brings the question about the role of combination therapies, because one drug can only do so much. One drug can lead to about 20-30% improvement over placebo. And so what if you were to combine 3-4 drugs that all had different mechanisms of action? Would you get incremental improvement in these patients?
Well, thank you very much. I think we may have time just for one last question, which is a great one that's answered in the chat box. Maybe hard to answer, but what is the effect of failure to maintain weight loss on after NASH in terms of improvement? Ping-ponging back and forth. Presumably, what is the effect of cumulative insults and fluctuations in weight on the natural history of NASH?
Yeah, that definitely leads to disease progression, because in order to see the improvement in histology, there has to be a sustained, weight loss, which is hard to achieve, like I mentioned. So the ping pong probably does as much harm as not, just keeping it on, because you're getting, the chronic inflammation that is happening and leading to the metabolic stress and downstream effects. So again, like I said, if I see a patient who's been working at this for years and they're up and down and back and forth, then it's about time to do something different to help the weight stay off.
Absolutely. Thank you again so much, Bubu, for this. Goodness, really appreciate it. I don't know if our friends from the ALF have further comments to the group or other parting messages, so I'll send it back to them. But thank you again very, very much, Dr. Banini.
Thank you so much. Thank you for having me. I enjoyed being here today.
Yes, absolutely. Thank you on behalf of the American Liver Foundation and everyone from the Connecticut region. Thank you for joining us tonight. And thank you, Dr. Banini and Dr. Cease, for planning all of this and getting it off the ground.
Thank you so much. Have a good night.
You as well. Good night, everyone.
Thanks again.
Thank you.